interested in improving the health of everybody in Scotland, throughout Scotland. But we know that if we're going to tackle health inequalities, we have to improve the health of the least advantaged faster than the most advantaged, or we're not going to make a difference. In 2012, we published our 5-year corporate strategy, and the title says it all. That's the mission, looking for a fairer, healthier Scotland. Every year, we also have a local delivery plan and a detailed business plan agreed with Scottish Government, which sets out what we're going to be doing in year. So how did we do? Well, there's a lot of detail in the self-assessment. I'd like to point out that we did well. In terms of our delivery commitments in our business plan, we delivered, or partially delivered, 92%. That's a really good performance. But what we set out in our corporate strategy is that we want to be held to account not just in what we do, what we deliver, or how well we do that, but about what difference we make. What impact are we having on outcomes? And in our strategy, we set out our 4 corporate outcomes, and there they are. We want to see fairer policy, we want to see stronger support for action, we want to see improved practice, and we want to be an excellent organisation. So I'm just going to look at how we've done in terms of working towards these outcomes. Looking at fairer policy, one of the big bits of work we did in year was for the Ministerial Task Force on Health Inequalities. We did a policy review looking at the most up-to-date evidence and what it tells us about what will work in tackling health inequalities, what's likely to work, and how we're doing in Scotland. Now, key to the policy review is this theory of causation, and you'll see this on placards in front of you there as well. And this is really very important because it makes the point, which I suspect we all know anyway, health inequalities don't sit on their own. They're related to other inequalities, and they're caused by some very fundamental underlying inequalities in power, resources, and money. You've also got environmental circumstances, and you've got individual circumstances in which people live, work, are educated in their lives. And if we are serious about tackling health inequalities, we have to see action in all of these different areas. Our other corporate outcome is on stronger advocacy, stronger for action. And again, as I said at the start, we have been part of the debate, and we want to continue to be part of the debate about what needs to be done to tackle health inequalities. We do that by producing evidence, research. We do that by engaging with key partners, people who can actually make a difference, make an impact. We communicate the case for tackling health inequalities and what needs to be done to do that. And we will continue with that role. In terms of improving practice, this is about making sure that everyone who has a role to play knows what that role is and is able to do it. And that's about how they can prevent and mitigate inequality. Because we're looking at all of the different causes, this is an incredibly wide range of our work, and I can't possibly refer to all of them, and indeed even our written self-assessment doesn't touch on all of the areas in which we work. Just to pick out some highlights for me, last year we published guidance for non-executive directors on health boards about what they can do, what health inequalities are, and what they can do and their board can do to tackle health inequalities and the sorts of questions they can ask. We produced guidance on health inequalities impact assessment. That's for anyone who's providing a service, so that you know what's the impact of the service. Is it being delivered equitably? Healthy working lives, we've got a number of programmes of work to support employers to be able to promote the health and well-being of their workers and to promote good work. Healthy Living Award, that's about making sure that people have access to healthy eating options. Early years, we do a range of work in the early years. One of these is making sure that anyone who works with parents with young children knows how to maximise their income. Pretty fundamentally important point in their role. And these are just some of the examples in the areas where we are working to improve practice in terms of health inequalities. Looking internally, we make effective use of our resources. We have met our financial targets, and particularly our efficiency savings targets, which are 1.9 million. I'd like to make the point, unlike other bodies, we don't get these savings to recycle. This is money that's taken out of our budget, and we've very successfully met those efficiency targets. We completed our estate strategy, consolidating our offices from 5 to 2, and this is going to give us a sustainable platform to look at ways of being as efficient and effective as possible. And I'd just like to take this occasion to pay tribute to Alan Crawford. Here, this is Alan's last day at work. After 22 years in the NHS, he's trying not to smile all day. Do you see Alan smiling? That's why. And I understand he left off this morning with an email to his fellow directors saying must do better. But I think that's the nature of Alan. It's the credit to Alan's hard work that we've consistently met our financial targets and our efficiency savings targets. And he's not letting up even in his last day. In terms of our staff, we aim to be an exemplary employer. In the annual NHS staff survey last year, along with other colleagues in the health service, we compared reasonably well, but along with others, we did less well in some areas than we had in previous years. As a board, we take this very seriously. There's a programme of work, an extensive programme of work to address this. It's overseen by our Staff Governance Committee and our Partnership Forum. We have a strong commitment to partnership working in Health Scotland. And I'd like to use this opportunity to pay tribute to Health Scotland staff, along with everyone else in the public sector and the third sector. We've had to cope with an awful lot of change this year. That's just how things are for us. Health Scotland staff have coped admirably and have continued to perform very highly. And particularly Health Scotland staff have stepped up. They've stepped up to implementing a fairer, healthier Scotland, being sure that what we do has that inequalities focus. And I'd like to thank Health Scotland for that and pay tribute to their hard work. Looking to the future bit, what is it that we're going to be doing in the next year? Again, we've got our business plan's an extensive document. We are going to be continuing to implement a fairer, healthier Scotland. We've got major programmes of work with community planning partnerships, particularly through the Inequalities Action Group. This was set up by the Ministerial Task Force on Health Inequalities. It's chaired by our Chief Executive, Jerry McLaughlin. And the emphasis is on the word action. This group is going to be identifying actions that community planning partnerships can take in tackling health inequalities. Major programme of work with the health service, particularly through the Health Promoting Health Service, but also other work that the health service can do focusing on health inequalities. Healthy working lives, continuing with employers, particularly small and medium-sized enterprises. We'll continue to have a role in advocating for action and engaging with partners in tackling health inequalities. And in terms of looking internally, well, we have our efficiency savings to meet, but we will also have a key focus on engaging and empowering our staff so that we can get the maximum from them. In terms of the challenges, well, the challenges are the same that face most of us. It's change and complexity. I mean, we all know in Scotland we're embarking on transformative change in public sector. Just a couple of examples: the new health and social care partnerships, new community and reinvigorated community planning partnerships, and a whole load of other changes. So that's a challenge. How do we as a national body help support local partnerships and do that in a way that's sensible, useful and effective? Reduced budgets, again, that's a challenge for everybody in the room. So for us, that means we have to continue to be as efficient as possible and very focused on the work that we do. And again, I think the big challenge that we still see is implementing a fairer, healthier Scotland and actually being able to make a difference and make an impact. So that's my brief presentation. I'm now going to hand over to Ian Welsh, who is the Chief Executive of the Health and Social Care Alliance, and Ian's the chair of our panel. So I'm going to the panel's going to hold us to account. So over to you, Ian.
Thanks very much, Margaret. We're just going to introduce ourselves quickly. As Margaret says, I am the Chief Executive of Health and Social Care Alliance Scotland, one of the third sector strategic intermediary bodies. I also serve on the Ayrshire and Island Health Board. I chair the Staff Governance Committee, and I'd applaud Health Scotland for this innovative way of addressing their stakeholders. I hope the health boards generally would take an enlightened approach to this. And I also chair the cohort of the University of the West of Scotland, which is a large health and social care teaching element to it. And I'll pass you along to the rest of the panel.
I'm Sarah Taylor. I'm Director of Public Health with NHS Shetland.
I'm Ron Cully. I'm the Chief Officer of Health and Social Care for COSLA. I should say that COSLA's Chief Executive, Rory Mayer, had intended to be here today but was pulled into a meeting with Mr Swinney at short notice, so you'll be me.
Good morning. My name's Ian Ross. I'm Chief Executive at NHS Lanarkshire.
Hello, I'm Aileen Keel. I've been Deputy Chief Medical Officer in the Scottish Government since 1999, and I'm currently Acting Chief Medical Officer.
Thanks very much. And just a few prefatory comments. I guess, as Margaret has said, we sit this week in the wake of one of the most alternately engaging and divisive debates we've had, democratic debates we've had in this country. And I think, however, we would all recognise the fantastic level of engagement that has taken place throughout the country. And I guess if we have to learn one thing that's non-political, that it's that level of engagement that we need to make in our health and social care services. I should say the CABSEC can't be here. He's in my ear here telling me that, however, the debate's wired for sound, Jerry, so you'll be reporting in due course on that as well. And again, just to say, Margaret, we do sit in the cusp of one of the most significant pieces of public sector reform with the introduction of the health and social care partnerships, and that will be I dare say, a fertile ground for Health Scotland as we move forward as well. I'm delighted that you're all here. There will be an opportunity for the audience to be engaged after the panel session, and I look forward to those questions. And I'm really pleased amongst all of you to see some strong third sector involvement. I see Callum Irvin from Voluntary Action Scotland, Janet Muir from Checks, and Paul White from SCVO, and others. But I think that also speaks to the space that Health Scotland are also occupying. We're going to look in four broad areas, I guess. We're going to do some questions on the self-assessment process, which Margaret has alluded to. We're going to try and unpack some of the issues around health inequalities during the course of this. We're going to pick up on some of the issues relating to welfare reform, which are current, and I suspect with the More Powers debate will be even more current in the next 4 to 5 months. And we're going to also look at NHS facing activity, given the statutory basis for Health Scotland as well. So without further ado, I'm going to ask Ron to start us off.
Thanks very much. I enjoyed reading the self-assessment that the organisation put forward. I think it was a very honest critique of where the organisation is. But I wanted to open up with a question about impact. And in particular, I thought that in reading the review, what came through was that there was a particular focus on inputs. In other words, the offer of the organisation of Health Scotland. And I just wondered whether or not there was an opportunity perhaps to focus more on outcomes. And when I say that, what I mean is that NHS Scotland presumably needs to go beyond just saying and doing the right things and take into account whether anything changes as a result. So I was hoping that the panel might comment on that.
I'm going to pass over to George to answer that in a minute, but I agree, it's something that as a board we have worked very hard at, because obviously our outcomes are quite long term, but we haven't shied away from that. in Health Scotland about being able to describe the difference that we're making, the impact that we're meeting. Rather than just said, we've done all of this and isn't it good and we've delivered it to a high standard. We are very keen that we are tied into national outcomes and an outcome framework so that we can actually demonstrate that we're making an impact. So I'm going to ask George to take that further.
Thank you, Margaret, and thank you, Ron. I suppose maybe the first acknowledgement to make on this is I can remember Mr Matheson asking us that question in my very first annual review in Scotland, so it's something that I know is on the minds of a lot of public sector organisations in Scotland. I suppose we'd want to take careful account of and recognise our responsibilities in being as accountable as any other public body in that respect, and a need to demonstrate impact. And I'm also mindful, I guess, Ron, that a lot of either organisations or people at the minute are finding their way to a CPP, planning partnership door to tell them what they need to be doing, as opposed to having a clear offer. I suppose in relation to the outcomes planning approach, Margaret covered off in her presentation the way I think through A Fairer, Healthier Scotland we've set out some pretty aspirational things around creating the conditions for improved policy, for improving practice, and for providing scope for stronger support for action. But I think underneath those broad outcomes, in many ways, I think the health outcomes that we're seeking to improve are perhaps those enshrined in either national policy or in local policy around single outcome agreements, for example. So it's recognising the contribution that we make to that. So it might be, in truth, in an annual reporting process, a fair reflection to describe a number of things that we've put in our self-assessment as inputs. And I guess some of the significant change work that, if you were to chat to some of our colleagues in this room today that we went through, was as a national agency we did struggle a bit with that. And we got to the point where we described those things in order to create the conditions for improvement either nationally or locally around the things that matter most for Scotland. So I think it's probably a fair reflection to say that we've described some inputs. I suppose if I give an example of levels of confidence, so because we use really strong evidence base and because we are absolutely rooted in kind of logical approaches to doing the right things in order to make a change. If you were to ask me whether something like, I don't know, in the order of an 18% reduction in suicide, say over the life of the 10-year strategy, what's Health Scotland's contribution to that? Is it 2%, 3%, 10%, or 12%? I'd find that impossible to answer. If you were to ask me, did Health Scotland make a really good and strong and valid contribution as a collective in a partnership arrangement, then I would have absolute confidence that the answer to that would be yes. And I think the truth and final thing perhaps to add is that the more you work in collaboration closely, either at national or local level or in partnership, the harder it is to disaggregate the single organisation contribution to that improvement and change. And I think that's something that most of my colleagues in the public sector would recognise.
Okay, then? Yep. Sarah?
Thanks. Another element of your self-assessment that I'm interested in talking about a little bit is you report on your staff survey results and thinking about your workforce and how they do the work that you've been describing. And in your self-assessment, you do well in many areas, but you also refer to particular challenges for you with your staff. And you mentioned three areas. You mentioned empowerment of staff, you mentioned communication and their involvement in decision making. And you do talk about some of the things that you've done over the last year to respond to your staff survey results. And you give some good examples perhaps of your organisation-wide responses. But you also talk about some of the improvement that's happened down in your directorates. And I wondered if you could give us some examples of that so that we can see how different parts of Health Scotland are tackling their own challenges that have been raised from your staff feedback.
I'll Kath respond to that.
Thank you. I think the first thing I'll say is, and it's certainly in no way to make an excuse around this, I think the issues that you've rightly said, Sarah, were highlighted, communication, empowerment and involvement in decisions, are probably perennial issues that most organisations would face, and particularly communication. I've not been in an organisation where that isn't an ongoing issue to get right. That said, I think the variety of ways that we've measured that and asked for staff feedback on that, the staff survey's been one, there's been other things as well. Consistently, these have been the issues. I'm really pleased with the way that we have looked at the staff survey this year compared with previous years, and that's, as you rightly say, has been not just to take it at the generic level of how's the organisation doing, but to break it down into directorate level, and that has been extremely useful. I think that was learning from previous times, that unless you do that, if you have fairly generic problems, you have generic responses. So absolutely this has been about taking those results and working with each directorate. And early days, and we've just got our staff survey out again just now, and we'll see what kind of comes back from that. But to give you a couple of examples, communication, as you say, was one of them. Within my own directorate, one of the very specific things we did with that was to make it a very explicit objective for every single manager within the team, recognising that communication can't just be top down, it can't just be bottom up, it has to be all things working together. So every manager has a specific objectives within their objectives this year to look at what they can do to improve communication within their team, and they need to do that by asking their team members what they need, and also about how do we back that up organisationally. So for example, we've developed a new corporate cascade, which is having the same key messages put down in a short bit of paper, given to every single director, every team, every month, to say these are the key things happening in the organisation. Don't just send that out by email, but use that to sit down within your teams and have a conversation about the things that are most relevant to them within that. So that's one of the things. We talked in the self-assessment about what we've called the functional alignment review, which is far short of an organisational restructure. We don't think that's appropriate, but we are taking various changes that are happening in the organisation, Alan's retirement, A Fairer, Healthier Scotland, to look at are we absolutely aligned and got all our staff in the right places doing the right things. When we did that, we explicitly thought about, again, feedback from the staff survey, that consistently staff do not always feel fully involved in decisions. I think to break that down a bit, they often feel they are consulted ad nauseam, but actually do they get feedback on what we've done and why, and what we haven't done and why. So we've taken that down, and I think another good example to get into the directorate level is the work that George has been doing with his delivery directorate, the biggest directorate. That is actively at the moment looking at about how can that directorate be redesigned to fully point towards a fairer, healthier Scotland. And that's been done with a cross-organisational group of staff within that directorate and other staff meeting regularly and working through and talking to staff and making sure that there are other engagement opportunities. So we've really been trying hard to work with that feedback. And what we'll do at the end of this process is test that back out with staff and see whether that has made a difference in terms of people being involved in decisions.
Thank you.
Sarah, can I add one thing to that? And that's we've been very serious about ensuring the staff side involvement in the design of the response to this. So the Partnership Forum within Health Scotland has played a key role in determining how we respond, and certainly it was both recommending and very supportive of the approach that we took to break this down by directorate and teams to try and understand where things work really well and where things can be strengthened. And finally, my own view is that the consolidation onto 2 sites gives us some additional opportunity to be able to grow some of that really good experience that happens, because I think we all recognise that this is just a continual improvement journey rather than one of having the right and the wrong answers.
Yep.
Can I just ask, you mentioned, Jerry, and going down to fewer sites, I think that always will help get clear messages, because sometimes they get lost in the giving. I noticed you had a high turnover in that move to the GAR. Was that really just because of the move, or do you think there's something to learn there from your staff surveys and pick things up from that?
I think this, I'll maybe ask Kath to come back on some of the detail. But so I think that was significant this year, but not the only driver. I think there is no doubt that not so much the facilities we've been able to provide at the Gael, but the location meant quite a changed journey to and from work for very many people. And there's no doubt that for some people that's made it much more difficult. We've done what we can to try and mitigate that, but the reality of that remains, and it certainly prompted at least some of our voluntary redundancy requests, by no means the majority, when we ran a small programme last year. I think
I think there are market forces from outside, and I think particularly with a relatively small health board with some really specialist functions, the career paths that we can offer are often relatively limited. And so I suspect we will always have a certain degree of turnover that's associated with just that characteristic.
Okay. Aileen?
Thanks, Ian. I think we can already detect an emerging theme from the panel that we're looking for really concrete examples around what you're covering in your self-assessment. And my question relates to healthy working lives. The self-assessment talks about you developing a new commissioning approach with more horizon scanning, engagement with partners. Margaret, you mentioned work with employers in this specific area. So can you give me an idea of what that would look like on the ground? What are you actually going to be doing with employers and other stakeholders to ensure that the Healthy Working Lives agenda is pursued?
I think Steve will be able to answer that.
Thanks, Aileen. I think, it's fair to say that that Healthy Working Lives, which is a pretty mature programme now, has evolved over quite a number of years, very much in response to some of the kind of environmental things that are out there and customer need. And at the moment, there are really three big things, in my view, which I hope come through the self-assessment that we're dealing with. The first is very much in keeping with what everybody else has said, that need to focus on health and equality, and to get that further up the agenda, and to change, therefore, the way that we do business. There's a second theme around continuing to respond to the needs of our customers, and very particularly SMEs, which is a challenge that's been given us. And let's make no bones about it, it's a very difficult market to be working with that particular customer group. And the third, which comes back to a point that Margaret made right in the opening comments, just around some of the budget constraints which we are under, which actually the NHS is under generally, is being able to deliver healthy working lives in a sustainable way over time. And what we need to do, and what we've sought to do, is to avoid anything which feels like salami slicing, but try to take a rather more strategic approach to change. And we're very, very fortunate, as I say, we are quite a mature programme. And we have a number of very good data sources that help us. So, for instance, market research, which we've run now a couple of times, there's more research currently underway, which gives us direct feedback from customers about the kind of services they want, the way we should communicate those services, the way we should deliver them. So taking that into account. We also have through, and of course Sarah's here representing one of the local boards, as of course is Ian. But having a network of advisors and staff employed within local boards also gives us tremendous local intelligence on what is needed. We're fortunate too in having very robust partnership arrangements. We have a national advisory and advocacy group in place which brings together partners from business, from other sectors as well indeed. I know there's certainly a representative here today. And we also take direct customer feedback. And we need to take into account other things, horizon scanning I mentioned, such as the new health and work service. So how do these things come together? And sometimes it's contradictory. I think we need to be clear about that. And one of the real challenges we've had at the moment, over the last 12 months, is around the balance between national and local focus and investment, and just where that needs to happen. So you asked for a really concrete example. So what we've been doing over the last 9 months or so, in actual fact, has been working with directors of public health, as well as managers of the teams that work locally and nationally, to think about how we could take all these matters into account. And we've come to a number of conclusions. So in very practical steps, what we're going to do to try to deal with some of the financial pressures and the need to get more efficient and work better cross-area is to establish and put together what we're calling hubs, or consortia of boards who can work together, so that we don't all have to have the same expertise. That's something that can be shared and therefore can be accessed by employers wherever they are, rather than purely in the areas where that expertise might be based. We're going to put in place a very formal partnership mechanism. Things have been quite loose, I guess, in the past would be a good way to characterise it, but a partnership board which will then commission services from hubs in the way that we see commissioning working. And it will also invariably deliver a change in the balance of delivery away from as much face-to-face work as we have been doing and more to phone and web. And we have very, very robust market research that supports that. But it's getting that balance right. What we know is that to access new customers, they really want to be being able to access us more remotely. But we also know from working with our existing client group that they really do value the benefits of having a member of staff that can work with them on whatever that issue might be across the wide range of things that we cover within Healthy Working Lives. So what I think we've come to, and there's still detail to be finalised, let's be clear, but it's very much a kind of best of both worlds approach, which does make sense of that limited resource, but which ultimately depends on that kind of really strong collaboration and partnership, which we've tried to work on over what's the best part of 10 years now.
Thanks. Ian, could I just ask a supplementary? Thanks for that. You mentioned a new kid on the block, the new health and work service. Can I ask how you were engaging with employers and GPs and others on that new concept? Well, it's building an established concept, but can you tell me what specifically you're doing around that area?
Before Steve's answer, maybe for the audience, if you could actually explain what that new service is, might be helpful.
Yeah, certainly. I mean, there's a new service which is going to be launched and will be rolled out slowly across Scotland commencing in December, which is to provide occupational health support fundamentally to employees right across Scotland. A support which will kick in after 4 weeks of absence. So this is a brand new thing in the sense that it's long-term funded. It's actually supported by both the DWP UK-wide and also Scottish Government. It's seen as a big priority. And very much builds on a lot of the learning which actually I've got to say has come from Scotland, and we've had quite a number of pilots around this ourselves and helped inform that kind of national picture. So there's been, again, I mean, it comes down to the strength of partnership, really. This is a collaboration. It's something which is going to be done through the NHS, which is not necessarily going to be the case in other parts of the UK, and which brings together the local boards in supporting delivery, as well as NHS 24, Health Scotland through Healthy Working Lives, and using our advice line, and also NHS Lanarkshire service in Salas as well. So in developing the kind of model for how we're going to run things, we've had exactly the kind of client groups that you mentioned involved. So input from clinicians, input as well from businesses, and indeed Health Scotland worked with and on behalf of Scottish Government in putting together an event with employers. This must be probably 4 or 5 months ago now, working with originally the Chambers of Commerce to get employers into a room and say, okay, so what does this service mean to you? How do you need to engage with it? And how can we support you to promote it? And we will be working closely with Scottish Government to use the very wide range of employers that we already have access to as customers, existing customers, so that they know about it, so that they use it, as well as to communicate more widely with some of the databases we have. And we see real benefits as well. Ostensibly, this is about dealing with an individual who has a problem and helping them back to work as quickly as possible. And we know that that's giving the best outcomes. Lots of studies have shown that. But this also gives us, and it's why there's an interest really from Healthy Working Lives, the opportunity then to be able to work with an employer on wider dimensions within the workplace. So why is it that member of staff presented with an issue? Why is it, or what is it that you could be doing to help deal with some of that proactively and preventatively?
Thanks, Steve.
Thanks, Ian. Can I just come in on that just to make an observation? I mean, this business of providing occupational health services to employers, not really new, been around for a long time, been in loads of incarnations, and I guess my just wearing a previous employment hat, I know that the third sector itself is generally very strong providers of that kind of rehabilitation and job retention activity. So that would, and I see Roddy's there. So it's Roddy Duncan from the Scottish Government. He's here to help us today. But you know, so there is a pedigree, and I guess when you're as old as I am, part of the issue is why does it take so long for a good service to be established. And my plea would be to make sure that in all the boards and others you make very strong contact with the third sector that have been providing this service. And I guess the other comment to make is I'll bet you if you analysed the healthy working lives as a percentage of Health Scotland's overall budget, it would be not a great deal. If you then extrapolate that as a percentage of the 12 billion quid that's been spent, it would be pretty marginal for a preventative upstream approach. So I'd be encouraging you to be trumpeting a bit harder and engage the third sector. Sorry, that was a party political broadcast on behalf of the nation. Sarah. This is the last question in this section.
Thank you. In many areas in the self-assessment, you're showing good reach. So reach meaning how well you engage. For instance, in 14 out of 15 boards, you've talked about engaging with smoking cessation pathways. 70% of community planning partnerships engaging through the bespoke website. I'm interested in your understanding of those parts of the system that you don't reach, and what your analysis is of that in terms of its importance in tackling inequalities. Coming from an island board, I'm well aware of the local context we have around remote and rural, and the challenge of reach in that context, but that's only one context. So I'd be interested in hearing some of your successes in terms of extending your reach into the areas that you're not engaging with so successfully, and perhaps your tactics for the future, for the challenges that you see coming around that.
Okay,
I'll let Jerry start off.
So I'll just make a very general comment and then probably pass to George and Kath to give some very specific examples, Sarah. But this is something that occupies a lot of our time, and indeed we may move on and talk a little bit about engagement with some very specific sectors. And we have, in the context of a reducing workforce and reducing budget, had to make some fairly clear choices about where we prioritise some of our efforts. And actually the strategic engagement with some of those sectors is exactly where we have prioritised some effort. We will turn in one of the examples, I think, very specifically to the challenge of remote and rural locations and communities in Scotland, because it's one of the areas in which particularly relatively small communities can get lost in the total national picture. So it has occupied quite a bit of our thinking time, and I'll pass over to George, and he may be able to draw out a couple of very specific examples of where we've gone and met either with boards themselves or with CPPs or with local authorities who have asked for our advice and our direction around that.
Actually, I'm just going to interrupt you before George. I mean, because in August I was actually up in the Western Isles with George and colleagues talking. We were invited up to talk to a community planning partnership, health and wellbeing committee. I spoke to the health board as well. And again, I think we often talk about this as though we go to remote and rural to tell them things. Well, it's not like that. We've as much to learn from how things work or don't work in remote and rural areas as the other way around. And I think that was very interesting for us. Not just that this was uniquely there, but it's about people's understanding of their communities and what the priorities are for action. We are, that's just one example where we have done that. But I would like to make that point, because folk talk about remote and rural like it's always, you're bringing stuff to them. We have as much to learn from how things work, particularly around about these really strong communities that you still find in remote and rural that we don't quite feel in the same way in urban areas. So what is it? What can we take from that, to urban areas as well? So, sorry, George.
That's okay, Margaret. I mean, I could perhaps come back to that, because I think the Western Isles work that we did is probably a good example of something that we did there. I suppose, so in saying that, Jerry and Margaret made quite clear that our analysis is that's very important to us as an organisation. And I guess a couple of things I'd want to acknowledge in front of the audience as well is that, for me, whilst I think it's very kind of you to point out the extended reach and places that we've got, I mean, reach isn't a proxy for impact. Any more than only focusing your work on SIMD1 is a proxy for tackling inequalities per se. So, I think just to recognise and acknowledge, Sarah, that we're pretty well aware of that. I think I suppose, Margaret, taking the Western Isles as an example, where the chair of the board had made a specific request for us to go and do a piece of work. If you look at, as we did, the single outcome agreement for Western Isles, one of the real challenges for them as a partnership was they were asking us for a bit of help in terms of improving national understanding of the situation that they often find themselves in, so that if you only look at the overarching statistics on a big level for Scotland, you might not see the Western Isles feature too much in terms of the worst health outcomes in Scotland. But if you look at the rural-only data, you start to see that some of the worst health outcomes there are on those islands. And then by going there, you start to understand also that it's not so easy to address them. So, if the mental health social worker's card stops at the end of somebody's drive, everybody knows that, and that can contribute to some of the barriers that people experience in terms of accessing services that can help improve lives. I think in terms of some of the successes, because I think you asked a couple of things in there, Sarah, so and Kath, you might want to cover the third sector stuff off in a second or two, but I suppose that piece of work with the Western Isles would be something I would describe as successful, because I think as a national agency I certainly came away with a much better understanding as a director about the things I might want to do in our business planning round for next time. I'd also point to a couple of quite practical things. So, I started with the suicide prevention example earlier, so let's stick with the theme. We know that if you live in a remote and rural location, or if you've experienced some life circumstances that mean that you need to have been looked after by a local authority at some point, that you're more vulnerable to suicide. So, you may have been involved in some of the work, Sarah, that we did on Shetland, specifically a couple of years back, I think, or in my time certainly. We've done something similar in Dumfries and Galloway, and some of the work that we've done with the Centre for Excellence around looked after children has led to some quite significant work in Glasgow. So even though Glasgow is not a remote and rural area, we're talking about a group of people who could be potentially quite vulnerable. So in terms of doing things in order to demonstrate impact at some point, as a result of that work, Glasgow have now embedded suicide prevention training for anybody who's anywhere near children who've been looked after by the local authorities. So, you hinted at some of the challenges I think in there as well, and I'd have to be honest and say, as ever, it's an ongoing challenge to measure the difference you make over time. It's a clear challenge to connect the various public sector improvement processes that there are lots of improvement things that are happening in places. So, and there's some of the bigger things that I point to. And also one of the challenges is that not everything that you try will work. So I think we've been doing some quite innovative work with Scottish Government and the Glasgow Centre for Art at the minute around some work in Highland. Now, the theory of that is you're working with local communities to get a real understanding about what matters to them to increase their levels of physical activity. What are the barriers? What are the incentives? What are the things that work? And that might not be jumping out the pile of results at the minute, but it doesn't mean to say you shouldn't have the appetite to try to do something different. So sometimes one of the challenges is maintaining that hunger to try to do innovative things, I would suggest. So perhaps I'm thinking there might be something on the third sector that Kath could add.
George, can I ask Kath to hold that point? Yeah. There's going to be something on the third sector. Maybe we could come in at that point. But I'm keen to go on to talking about health inequalities more specifically, having crossed off some of the self-assessment stuff. And Aileen's got a question to start us off.
Thanks, Ian. Well, this for sure ain't a straightforward area. So, my question is, given the wide range of factors which contribute to health inequalities, where would Health Scotland advise the immediate focus should be in terms of the wider environmental influences and/or individual experience to begin the transformational change that we need in this area? So, in other words, give me some concrete examples of where you put your best bet for things that will really lead to improvement in this very complicated area.
Jerry, if you'd like to start off.
So I'll introduce this, and then Andrew, I think, will come to some of those concrete examples, Aileen. I think it's really important that we say that right from the start, when we set out our strategic approach, we argued that it was critical that we had a very balanced approach to our work, from continuing with interventions, which has been where the majority of Health Scotland's work in its first 10 years had lain, interventions at an individual level, looking at lifestyle, looking at behaviour change, and how we continue that work to mitigate the impact of inequalities, then balanced with both those wider environmental influences and indeed some of the fundamental structural drivers for inequalities. And we know the WHO analysis of what those key drivers are. So what I would say to start off just with that individual intervention, Aileen, is that what we have been trying to do in the last couple of years as we develop our implementation of our strategy is to make sure that all of those individual lifestyle and behaviour change interventions are designed and assessed for their impact in reducing inequalities. So before we design a smoking cessation programme, before we design a new intervention around, maybe brief intervention around alcohol, before we design some of those early years interventions, let's assess the design of our programme first and foremost about what impact that will have on inequalities, for the very obvious reason that we know that approaches to improving average population health often will either make no change to that gradient of outcomes, or indeed, at worst, they will actually make that gradient even steeper. So Andrew will give you a couple of now of quite specific examples of where we've looked at that.
Thanks. Well,